Yes, thank you very much, Anastasia. Thank you for inviting me again to Vienna. Well, as we've heard before, ground glass is a very non-specific finding, and if all causes of infectious or inflammatory ground glass are considered, you will end up with an impossibly broad differential. However, the number of diseases that cause infectious and inflammatory ground glass in isolation or as a predominant finding is relatively small and can be prioritized based on simple clinical information. There are basically 4 clinical settings in which infectious or inflammatory ground glass in isolation or as predominant finding can be encountered. Patients who are immunocompromised, patients with acutely developing dyspnea, outpatients with slowly progressive dyspnea, and patients who are receiving bone marrow suppressing chemotherapy. And in these patient groups, ground glass may be either acute or chronic and therefore change over time, may be a helpful pointer. Now, in the first clinical scenario, an immunocompromised patient will present with dyspnea and often fever. There'll be a history of HIV infection, organ transplantation, or steroid therapy. And in this setting, the primary differential diagnosis includes opportunistic infections. PCP pneumonia remains the most common opportunistic infection in HIV-positive patients and is also common following organ transplantation with a significant mortality. Patients will present with fever, cough, dyspnea, and marked hypoxemia. In patients undergoing steroid therapy, the most common presentation is the occurrence of fever, dyspnea, and ground glass toward the end of the steroid taper. On high-res CT, ground glass may be either uniformly distributed or may occur in a mosaic pattern. With more severe disease, it may progress to consolidation. PCP pneumonia may take a variety of more unusual patterns, such as apellopredominance, nodules, or cystic lesions. CMV pneumonia is also very common in HIV-positive patients or in patients who have undergone organ transplantation. Many of the patients are asymptomatic. If symptoms occur, fever, cough, dyspnea, and an increased alveolar arterial gradient are common. On high-res CT, there's diffuse isolated ground glass opacification or small nodular lesions, as in this patient. Again, in more severe disease, diffuse consolidation may occur. The differential diagnosis of PCP and CMV pneumonia is often impossible based on imaging findings alone. Thirdly, herpes simplex pneumonia is a rare reactivation infection which occurs in immunocompromised patients, newborns, or ICU patients who will present with dyspnea, cough, and fever. On high-res CT, ground glass will appear in a multifocal, segmental, or subsegmental fashion, may be mixed with patchy consolidation, and there are commonly small pleural effusions as well. Second scenario. In patients with acutely developing dyspnea, ground glass is commonly due to one of the alveolar causes of ground glass opacification: pulmonary edema, ARDS, or diffuse pulmonary hemorrhage. While the list of disorders known to cause diffuse pulmonary hemorrhage is long, however, the CT occurrences, the CT presentation is essentially the same regardless of the underlying etiology and includes patchy ground glass or centrilobular nodules, ground glass admixed with consolidation in more severe disease, and crazy paving in resolving diffuse pulmonary hemorrhage. Crazy paving is the combination of interlobular septal thickening and ground glass opacification. In the third clinical scenario, an otherwise healthy outpatient will present with slowly progressive dyspnea. And in this context, diagnosis includes chronic interstitial lung diseases, and particularly in this context, the depiction of ancillary findings such as signs of fibrosis, cystic lesions, lymphadenopathy, and so on, and the analysis of subtype patterns is helpful for differential diagnosis. Now, the first subtype pattern I'd like to discuss is the combination of diffuse ground glass opacification and faint micronodules. And there are basically 2 disorders that need to be discussed. RB-ILD, respiratory bronchiolitis, interstitial lung disease, and subacute hypersensitivity pneumonitis. And you will frequently need the smoking history in order to differentiate the two diseases. Let's start with hypersensitivity pneumonitis. Well, the long list of agents known to cause hypersensitivity pneumonitis can be organized in three major categories: microbial agents, animal proteins, and low molecular weight chemicals. However, regardless of the antigen, only a small minority of exposed or sensitized patients will develop hypersensitivity pneumonitis. Histopathologically, there's an interstitial pneumonitis. It's a purely interstitial lung disease. Pneumonitis tends to be bronchiolocentric, and they are poorly formed, so-called non-necrotizing granulomas. On high-resolution CT, ground glass is the predominant finding, may be patchy or diffuse, and is essentially reversible when the exposition is discontinued. Commonly, there are centrilobular ground glass nodules with a middle or lower lobe predominance, and air trapping, which is a very important ancillary finding, very helpful for differential diagnosis, and a small percentage of the patients will display cystic lesions as well. This was a bird fancier with subacute hypersensitivity pneumonitis. There's a centrilobular micronodular pattern, ground glass nodules all over the place on a background of ground glass opacification. Ground glass is even more pronounced in this patient. This female patient displays cystic lesions as well. 10% of the patients with subacute hypersensitivity pneumonitis do so. A mosaic pattern is present in the vast majority of the patient. Mosaicism is the combination of patchy ground glass and lobules with decreased density reflecting air trapping. And one study has indeed shown that the depiction of multiple lobules with mosaicism in more than 4 lobes allows a confident diagnosis of hypersensitivity pneumonitis. Again, a patient with obvious mosaicism, obvious air trapping in the lower lobe, ground glass opacification again as predominant finding, and scattered cystic lesions as well. As I said, the major differential diagnosis in patients with this subtype pattern of diffuse ground glass and faint micronodules is RB-ILD. Well, respiratory bronchiolitis is a very common finding in heavy cigarette smokers, and it refers to macrophage-predominant inflammation around the small airways. However, these individuals do not have any clinical symptoms, and there is no significant interstitial lung disease. In a certain percentage of the smokers, however, respiratory bronchiolitis is associated with interstitial lung disease, and it is this disorder that has been termed RB-ILD. Patients are middle-aged. They suffer from a gradual onset of shortness of breath and dry cough, and the most important therapeutic approach, of course, is smoking cessation. Histopathology shows accumulation of alveolar macrophages within the respiratory bronchioles spilling into neighboring alveolar air spaces, and there's a mild mononuclear cell infiltrate. High-res CT closely mirrors histopathology as fluffy centrilobular micronodules reflect macrophage accumulation in the respiratory bronchioles, and the background of ground glass reflects macrophage accumulation in the alveolar air spaces. Ancillary findings are a few areas of decreased attenuation, few thickened interlobular septa, and some emphysema and mild bronchial wall thickening. In general, the high-res CT findings in patients with RB-ILD are variable, non-specific, and often subtle. Look at this big-time smoker with RB-ILD. There's a centrilobular micronodular pattern with ground glass nodules predominantly in the upper lobes, and this patient on a subtle background of ground glass opacification. Ground glass is even more pronounced in this patient with RB-ILD. Again, there's a micronodular pattern as well. And a third patient with ground glass, again, as the predominant finding, and a little bit of air trapping in the lower lobes as well. One benchmark study by Rémi Jardin and co-workers has shown that interestingly there was replacement of the micronodular pattern by emphysematous lesions in persons who continued to smoke, indicating that potentially respiratory bronchiolitis may be a precursor lesion to emphysema in patients who continue to smoke. The next entity we need to discuss is desquamative interstitial pneumonia, DIP, which is also a smoking-related lung disease. However, there is an association with other disorders as well. The patients are middle-aged and present with slowly progressive dyspnea and dry cough. Most of them will recover upon steroid therapy and smoking cessation. However, some will still deteriorate despite treatment. Histopathology shows uniform and extensive filling of the alveolar air spaces with macrophages, and there's very fine fibrosis of the interstitial septa, the alveolar septa. On high-resolution CT, again, ground glass is the predominant finding. It may be uniform or heterogeneous and reflects partial air replacement by the macrophages. There may be interstitial fibrosis, commonly shown by intralobular lines. Honeycombing, by contrast, is very rare in these patients. This was a big-time smoker with biopsy-proven DIP. Again, ground glass is the predominant finding. It is diffuse and homogeneous in this patient, and there's quite a bit of periseptal emphysema as well, indicating the smoking history of this patient. Well, you can see from the numbers published in the literature that DIP is an extremely rare disorder. In the very few longitudinal studies that exist, most patients showed a decrease in the extent of ground glass, in the extent of disease. All remained stable. However, some deteriorated or progressed despite treatment. Just two examples. This was a big-time smoker with DIP. He presented with diffuse ground glass pacification, tiny little bit of reticulation as well in the subpleural parts of the lung, and he showed a decrease in the extent of disease upon smoking cessation and steroid therapy. This patient remained pretty stable, but he showed a greater extent of reticular pattern as well, with traction bronchiolitis, the subpleural parts of the lungs, indicating irreversible fine fibrosis. And this leads me to the next subtype pattern in patients and outpatients with slowly progressive dyspnea. The combination of ground glass pacification, reticulation, and traction bronchiolitis. And the entity that we need to be talking about here is NSIP, nonspecific interstitial pneumonia. Well, the term nonspecific is somewhat misleading, as there are specific histopathologic findings and also frequently specific high-res CT findings, at least in the fibrotic subtype of the disorder. A very important point is you should always use the term NSIP pattern when you're reporting CT scans. Why? Because you need to rule out underlying disorders which may be associated with an NSIP pattern, both on high-res CT and on histopathology, such as hypersensitivity pneumonitis, drug toxicity, or collagen vascular diseases. So it's very important to talk about the NSIP pattern. By contrast, idiopathic NSIP is now included as a discrete entity in the revised classification of the idiopathic interstitial pneumonias, but it also requires a multidisciplinary approach, including clinicians, radiologists, and pathologists, because, as I said, underlying disorders, underlying systemic disease needs to be ruled out. Histopathology shows uniform involvement of the alveolar septa with inflammation and variable degrees of fine fibrosis. On high-res CT, ground glass again is the predominating feature. It's present in almost all of the patients and may occur in isolation in about 1/3 of the patients. It's frequently confluent, bilateral, symmetrical, and may show a lower-low predominance. It's commonly associated with a reticular pattern with traction bronchiectasis and bronchiolitis. Honeycombing is extremely rare, may occur in less than 5% of the patients. Very important point. Findings may show a peribronchovascular distribution, and there may be sparing of the immediate subpleural parts of the pulmonary parenchyma in about 20% of the patients. This was a patient with idiopathic NSIP, and high-res CT again shows ground glass as predominant finding, but it's not pure ground glass. You will depict a very fine reticular pattern with very subtle traction bronchiolitis, indicating that this is all very fine fibrosis. Fibrosis is even more obvious in this case with idiopathic NSIP. There's traction bronchiectasis and traction bronchiolitis as well, and a very prominent reticular pattern, and there might be a little sparing of the subpleural parts of the lungs as well. And a third patient with NSIP again, ground glass opacification as predominant finding, associated reticular pattern, and very subtle signs of fibrosis with traction bronchiolitis and traction bronchiectasis. Make sure to depict ancillary findings suggestive of an underlying disorders in patients with an NSIP pattern on CT, such as dilation of the esophagus, and this patient with NSIP associated with scleroderma. Serious studies have shown that ground glass did regress, was potentially reversible. However, in one long-term study, ground glass was replaced by fibrosis. And you should know that the prognosis of patients with NSIP is very variable. And in one study, 28% of the patients who presented initially with a typical NSIP pattern on high-res CT progressed to findings suggestive of idiopathic pulmonary fibrosis or a UIP pattern. So you never know. Now, the last subtype pattern I'd like to discuss in the context of an outpatient with slowly progressive dyspnea is the combination of ground glass and cystic lesions, and the entity I'd like to mention is LIP, lymphoid interstitial pneumonia. LIP is due to diffuse reactive pulmonary lymphoid hyperplasia. It is rarely idiopathic, but is more commonly associated with Epstein-Barr virus infection, immunosuppression, or collagen vascular diseases, particularly Sjögren's syndrome. It has a female predominance. Patients present with a restrictive lung function deficit, and histopathology shows a lymphoid interstitial infiltrate. Fibrosis, however, is very rare. Again, ground glass is the predominant finding on high-res CT. It is associated with thin-walled cystic lesions, which may show a peribronchovascular distribution. Ancillary findings include centrilobular nodules or interlobular septal thickening. There may be mediastinal lymphadenopathy, which is very frequent in patients with Castleman's disease. And serious studies have shown that ground glass did regress. However, nodules may develop to cystic lesions. This is a very rare case of idiopathic LIP. High-res CT shows diffuse ground glass opacification and thin-walled cystic lesions. A patient with Castleman's disease, you will depict extensive mediastinal lymphadenopathy in this patient, and he showed ground glass opacification as predominant finding and thin-walled cystic lesions with, in this case, peribronchovascular distribution. Well, there are two other causes of chronic diffuse ground glass opacification in the context of an outpatient slowly progressive dyspnea, and these are really the two chameleons among chronic interstitial lung diseases. That's the first patient. He presented with patchy ground glass opacification and a little bit of consolidation as well. And his high-res CT scan showed thickening of neighboring interlobular septa, producing these arcade-like structures, and we call this the perilobular sign, and this is fairly characteristic of organizing pneumonia. First chameleon, second chameleon, high-res CT scan with diffuse ground glass opacification. However, this is not pure ground glass. You will note this very fine stippled appearance, this subtle nodularity all over the place, and this is a patient with sarcoidosis. Well, in the last clinical scenario, a patient who is receiving bone marrow suppressing chemotherapy will present with thrombocytopenia and neutropenia and present with respiratory symptoms. And of course, differential diagnosis includes opportunistic infections as well as diffuse alveolar hemorrhage. However, in our experience, drug toxicity is the commonest cause and the commonest differential diagnosis which needs to be considered. While there are several histopathologic patterns of drug toxicity, note that a number of them will present as diffuse ground glass opacification on high-resolution CT. Well, of course, a detailed discussion of all drugs causing ground glass opacification on high-res CT is beyond the scope of this talk, and I'd just like to show you a few examples. This was a female patient with rheumatoid arthritis, and she was on methotrexate, and she presented with diffuse ground glass opacification, a little bit of consolidation in the dependent parts of the lung as well, and this was a case of diffuse alveolar damage. Second case, excuse me, a male patient who was on amiodarone. His high-res CT scan shows diffuse ground glass opacification associated with a reticular pattern of traction bronchiolitis, and from what's been said before, it is clear that this is an NSIP pattern. Thirdly, a male patient with non-Hodgkin's lymphoma who was on bleomycin, and he presented with patchy ground glass opacification and a little bit of admixed consolidation as well, and this was organizing pneumonia. Very important point to make is that in patients with collagen vascular diseases in particular, it is frequently very difficult to differentiate ground glass secondary to drug toxicity from ground glass secondary to pulmonary involvement. And in these cases, it is frequently required to discontinue the drug. Just an example, a female patient with rheumatoid arthritis. She was on methotrexate and presented with diffuse ground glass opacification, a little bit of reticulation as well. And of course, differential diagnosis in this context included pulmonary involvement or methotrexate pneumonitis, and these findings entirely disappeared upon drug cessation. Let me just summarize my talk. In the differential diagnosis of infectious or inflammatory ground glass, change over time is a very helpful pointer. Acute ground glass is encountered in pneumonia, diffuse pulmonary hemorrhage, or pulmonary edema. Chronic ground glass may be seen in RB-ILD and DIP, smoking-related lung diseases, NSIP, sarcoidosis, or organizing pneumonia. However, in our experience, clinical information is by far the best means to narrow differential diagnosis, and therefore let me just briefly summarize the 4 clinical scenarios I've presented. In immunosuppressed patients with acute ground glass, consider opportunistic infection. In acutely dyspneic patients with ground glass, think of pulmonary edema or diffuse alveolar hemorrhage. In patients receiving bone marrow suppressing chemotherapy, consider drug toxicity. And in outpatients with slowly progressive dyspnea, differential diagnosis includes chronic interstitial lung diseases, and particularly in this setting, the analysis of associated findings and the depiction of subtype patterns is helpful for differential diagnosis. Thank you very much.